Hello and welcome. On behalf of CME Outfitters, I would like to welcome and thank you for joining us for this CMEO snack titled Updated Strategies for Early Detection and Prevention of Anal Cancer. This activity is supported through an independent educational grant from Merck & Company from Rahway, New Jersey. And today's activities may include discussions of products or devices not currently labeled for use by the US FDA. I'm Joel Palevsky. I'm a professor of medicine at the University of California, San Francisco. I have the pleasure of being joined today by Tonya Poteet, who is a professor at Duke University School of Nursing in Durham, North Carolina, and Daniel Garza, who is an advocacy director at a beautifully named entity called Cheeky Charity in Laguna Beach, California, which advocates for better colorectal and anal cancer prevention and early detection. Welcome to both of you.
Happy to be here.
To frame the discussion today, let me review today's learning objectives. The first is to identify patients who may be at increased risk of developing anal cancer. The second is to incorporate routine anal cancer screening into the care of patients at risk of anal cancer. And the third is to talk about engagement in respectful and sensitive discussions around anal cancer prevention measures with patients and other members of the interdisciplinary healthcare team. I thought it would be interesting to kick us off with what I think is the most important focus today, which is the patient focus, and hear a personal story from one of our panelists today. And Daniel has kindly agreed to talk to us about his experience. So I'm going to turn it over to Daniel to tell us his story.
Thank you. Hello, everybody. So my anal cancer story starts actually 25 years ago when I was diagnosed with HIV. So I've been living with HIV for 25 years. And uh, in November of 2014, started having some symptoms, which were confused for other diagnoses. I was bloated, I was having trouble going to the bathroom, or spotting. And some of the symptoms that the doctor was noticing were easily confused. First, it was hemorrhoids, then it was my diet, then it was my sexual activity. So every time we talked about it, it was just something different. So for those of you who know me, I use a lot of comedy in my presentations. So I always say I was either too Mexican or too gay, and that's where my diagnosis was coming from. And I think that's where actually the idea of becoming an advocate, because I knew something was wrong with my body, uh, particularly when you're a long-term survivor of anything like HIV. You learn to connect with your body, and I knew something was wrong. So finally, in May 5th of 2015, is when I got my diagnosis back. So I went to the colonoscopy, went through the probes to make sure if there was a mass there, and the results came back as anal cancer. Uh, the initial shock, I don't think the initial shock was actually that I had cancer. Something in the back of my mind already was leading me that direction. And like many of us, I went down the Google rabbit hole and started like looking up symptoms and self-diagnosing. And when you're a lifetime advocate, you kind of think you're smarter than most doctors. And but what really, really surprised me was that as a long-time HIV educator, presenter, advocate, activist, I never knew about the cancers that living with HIV I was more prone to than if I had living without HIV. And I think that was the biggest frustration, that within the community, we never really talked about it. So once I was diagnosed and started talking to other Latino men and other gay men about anal cancer, I realized that a lot of people didn't have the proper information. So I know it's sad, but it made me feel less bad about myself that I wasn't the only one that wasn't aware. So after chemo and radiation, and we did hyperbaric chamber treatment to try to and revive some of the cells, which actually worked in some parts of my body, got great hair. We came out of it. So this May of 2025 was 10 years from an initial diagnosis. And unfortunately for me, there were some complications with radiation, which caused fistulas and problems. And the cancer was on the sphincter. So when the cancer was removed, it also took half of my sphincter with it. So that required me to have an ostomy surgery. So I have a colostomy. His name is Tommy, and we've been together now for 9 years. And just to put it out there, how the universe likes to joke around, my surgery was on April 1st of 2016, April Fool's Day. So I live by holidays. But that's pretty much in a nutshell what the journey has been like. Where I am today is just uh, there is some body dysmorphia, obviously with the cancer and the ostomy bag. There's a lot of discomfort still sexually. Uh, Luckily, my partner who was with me when I was diagnosed, we're still together 13 years later. I have a great support system, but it definitely triggered some anxiety and some depressive modes in me. And those are things that I still have to deal with today. So that's part of the story. Thank you.
Thank you so much for sharing that, Daniel. I really appreciate it. One of the issues that we'll be talking about later is the stigma and the difficulties around talking about this disease in general. And when people are willing and able to come forward to discuss their experiences, it's a tremendous help to everybody. And it sounds like your story is typical in many ways of the anal cancer patients who we've seen in our practice, where there's the shock around the initial diagnosis and then uh, challenges during and after the therapy, which persist long after the completion of the therapy. So again, thank you for sharing your story with us, and we'll come back to many elements of it in the next little while. So I would like to turn our attention now to discussing the populations at risk for anal cancer. Anal squamous cell carcinoma, or anal cancer, is actually a relatively rare disease in the population. This is one of the reasons why we don't hear too much about it. It's only found in general at around 2 cases or so per 100,000 person years. So it's not high on people's radar. But there are other reasons too why we don't talk a lot about it. And some of that has to do with the stigma that we've alluded to, including issues around sexual behavior, questions people have about sexual orientation, the stigma associated with the specific anatomic site in question, namely the anus. So all of these, I think, present potential barriers to people being more open to discussing their concerns around being diagnosed with anal cancer or seeking medical care. Anal cancer is not actually a big mystery in terms of its biology. In many ways, it's very similar to cervical cancer. More than 90% of anal cancers are, in fact, associated with the same virus that causes cervical cancer, which is human papillomavirus. And it goes through a similar natural history. Obviously, it's not exactly the same disease because the anus has a very different function from the cervix, but there are an awful lot of similarities that allow us to take lessons from what we've learned in the cervix and apply them to prevention and treatment of the disease. As I'll show in the next slide, the natural history is quite similar. You get HPV infection early on after initiation of sexual activity. More than 85% of us who are sexually active are going to get a genital HPV type or more at some point in time during our lifetimes. And then it goes through a progressive set of stages up to and including the development of anal cancer in a relatively small proportion of people who get the initial infection. The treatment of the precancer lesion is now shown to be effective in reducing the risk of anal cancer. And this is one of the major steps forward in the last few years, which really allows us to talk about important prevention steps, not only primary prevention in the form of vaccination, but the main focus of this session today, which is secondary prevention, to look for that high-grade precancerous lesion and remove it before it can turn into cancer. So that's shown on this slide. This is a diagram that was initially made for cervical disease, but it applies equally well for anal disease. On the left side of the slide, where it says normal, is a normal epithelium. HPV infects in the basal cell layer, establishes a more or less permanent reservoir of infection, and in just a small proportion of those infections will lead to what we call the low-grade squamous intraepithelial lesions, or LSIL. CIN1 is one form of it in the cervix. Warts in the anus or the cervix is another form. And this represents the actual replicative state of HPV. Here, what you get is a lot of virus being formed and spread, but not a lot of transformation. So these LCIL lesions are very unfortunate for the patient. They cause a lot of psychological stress, depression, traumas, some symptoms like itching, but they do not generally progress to cancer. The other form of natural history that occurs, and it tends to be binary, is progression to HSIL, high-grade squamous intraepithelial lesions. That's CIN2 or 3 in the cervix, AIN2 or 3 in the anus. This is, in fact, the precancerous lesion. This is what we're looking for when we're doing cervical pap smear screening and what we're looking for when we do the equivalent in the anal canal and perianal area. The idea here is that instead of forming a lot of virus like you see in the low-grade lesion, instead the virus expresses transforming proteins, doesn't make a lot of virus, but instead changes the cell and transforms it into a potentially precancerous state. So if they're left alone long enough, a small proportion of these can pierce the basement membrane, which by definition makes it cancer. And this is what we're trying to prevent when we're looking for these high-grade lesions. And if they're found, then we move on to treatment to remove them to prevent that progression step. This has been shown to work very well for the prevention of cervical cancer. Remember, we talk about primary and secondary prevention of cervical cancer. Primary prevention is prevention of acquisition of the causative agent, HPV, through vaccination. Secondary prevention is for people who haven't had the vaccine or who haven't benefited from the vaccine to look for, as the next opportunity to prevent cancer, the high-grade lesion and remove it before it progresses. So when that happens, again, it's a relatively uncommon occurrence since a very high proportion of us will get an HPV type. Only a small proportion of those who get HPV will develop the cancer, but it's still too high. In the case of anal cancer, as we've said, it's a relatively rare cancer, but it's important to note two things. The first is that in the general population, even though it's rare, the incidence is increasing. It has been increasing by at least 2 to 3% per year in the general population since the 1970s, and the incidence continues to rise. But the other very important thing is that there are well-known groups at especially high risk of anal cancer from the population. And these are the groups in whom the incidence of anal cancer is unacceptably high and who form the first set of natural targets for a screening and prevention program for prevention of anal cancer. So if we look at who those groups are, they tend to fall into one of five categories. They include three groups of people with HIV infection. These are men who have sex with men with HIV. They are males who are with HIV, but who are not men who have sex with men. And then there are women living with HIV. These three groups are very important. The highest risk group of all actually are men who have sex with men living with HIV. And the incidence tends to go up with age. So men who have sex with men who are 60 years or older living with HIV are the highest risk group of all. This group tends to have an incidence of anal cancer of over 100 per 100,000 per year. And to put this in context, the incidence of cervical cancer in a screened population in the United States is on the order of 6 to 8 per 100,000 every year in the United States. The men who have sex with men are the highest risk group, as I mentioned. Men who are living with HIV, who are not MSM, are at lower risk, but still too high a risk. They're on the order of about 30, 35 per 100,000. And again, the incidence increases with age. And women are also at too high a risk. They're on the order of about 25 to 30 per 100,000. Again, higher risk with increasing age. There are two other important groups to bear in mind as well. In addition to the three that we've already discussed who are with HIV, they include women who have HPV infection elsewhere in their genital tract. primarily in the vulva. So women with a history of vulvar high-grade disease or vulvar cancer are at increased risk of anal cancer. And that makes sense because we think that in many cases, women may have had spread of HPV from their vulvar region to the anus, and that's how they got anal HPV infection. And once again, the rate increases with age. There's also an increased risk with women who have cervical cancer and to some degree cervical precancer and also vaginal cancer. So when we're talking about women, there are two opportunities to get anal HPV infection. One is through acquisition through sexual behavior. The other is spread from the other areas of the genital region that are susceptible to HPV infection, such as the vulva and the cervix. So women with a history of high-grade disease or cancer in the vulva primarily, but also the cervix, are at increased risk. And then the last group are people who are immunocompromised for reasons other than HIV. And this includes largely people who have a history of solid organ transplant, primarily renal transplant, and who are iatrogenically immunosuppressed to prevent graft rejection. Here, the pattern is a little bit different when it comes to age. In all of the other groups I've discussed, the incidence increases as a function of age. Here, it's not so much age, but rather the number of years of people post-transplant. So people who are more than 10 years post-transplant are at the highest risk. And what that says is that in addition to biological age, another important factor that may increase the risk of developing cancer is the duration of immune suppression. There's one more group that I want to talk about, shown on this slide, and that's HIV negative men who have sex with men. This is a group that is also at increased risk, not as high as men who have sex with men who are living with HIV, but still quite a bit higher than the general population. Once again, we see the same age relationship. And here, men who have sex with men who are not living with HIV, but who are older than 60 years, have rates about 30 to 35 per 100,000. Again, quite a bit higher than the general population. So the main risk groups to consider when thinking about who to focus first on prevention efforts would include the 5 groups that I've mentioned before, the 3 groups living with HIV, women with a history of cervical or vulvar HPV-related disease, and people who are immunocompromised due to other reasons, including transplant. And then lastly, as shown on this slide, men who have sex with men who are not living with HIV, but who are on the older age of the spectrum, typically older than 45. So there have been some big changes in the field regarding thinking about screening and how to screen. And as a result of that, there are some new things to think about. One of the reasons why we haven't been screening in the past, because of, or despite the high rate of anal cancer, has been that we haven't really had a lot of evidence that those screening approaches worked. These are difficult studies to perform, and while there have been guidelines in the past from a variety of different organizations, they've largely been expert opinion based and did not have the highest level evidence showing that they work. That didn't mean they didn't work. It just means we didn't have the evidence to prove that they did work. And for that reason, it's been challenging to implement widespread screening programs in these high-risk groups as much as we might have liked. It was known for a long time that HIV was a risk factor, and so some of those earlier guidelines, such as those from the American Society of Colorectal Surgery, from CDC and other groups, IDSA, were largely focused on people with HIV. But the big step forward, I think, has been the publication of the Anchor trial. Why is that? That's because this trial was done to provide the kind of evidence that we think we need to really get widespread buy-in and adoption of these screening programs. Anchor is an acronym. It stands for Anal Cancer HSIL Outcomes Research Study. And this was a study that was designed to provide randomized controlled trial level evidence to see whether the treatment of anal HSIL reduces progression to anal cancer, just like we already know that treating cervical HSIL reduces progression to cervical cancer. So the way this was done was that individuals living with HIV, 35 years and older, now you know why we focused on people who were older, with biopsy-proven high-grade disease, that was AIN3 or P16 positive AIN2, were randomized to one of two groups, treatment of that HSIL using the best methods that we had available, or observation, in which we followed people very carefully without treatment. We called that the active monitoring group, and then followed them up over time, where the outcome was progression to cancer. The other major outcome, of course, was the safety of treatment. The results of this study were published in the New England Journal a couple of years ago now. And essentially, we enrolled 4,446 individuals who were diagnosed with biopsy-proven high-grade disease. We had a median follow-up of a little more than 2 years. In the treatment arm, there was still some cancer that developed, 9 people. But in the monitoring arm, where we followed people without treatment, there were 21. That was a 57% reduction in the incidence of anal cancer. You can see the graph on the right showing the divergence of the two arms. The blue one is the active monitoring arm. The red one is the treatment arm. And the incidence is shown to be 173 per 100,000 people with high-grade disease progressing to cancer in the treatment arm versus more than 400 in the monitoring arm. So that's a nice difference, resulting in that statistically significant reduction in progression to cancer. I see two messages there myself. One is that, yes, we did see a nice difference. The other is I still think that 173 per 100,000 is too high. And although treatment definitely works, the other message is that we still have a little ways to go, because I'm hoping that we can do even better in the future. So the data from Anchor actually provided the kind of high-level evidence that we all felt we needed to move forward with putting out a new set of guidelines. And I would actually like to invite my co-panelist, Tonya Poteet, to take us through those guidelines and who's recommended what and how they're different and how to get going. So Tonya, over to you.
Thank you, Joel, and thank you for the Anchor trial and for sharing the results with us. That really was a sea change in how we think about preventing anal cancer. I'm going to start with a slide that describes the updated International Anal Neoplasia Society consensus guidelines. And they pretty much follow the epidemiology that's already been described. On the left-hand side, you'll see the populations to screen, and they're divided into two categories. Risk category A are folks who have a cancer incidence that's more than 10-fold higher than the general population. And that includes the groups that Joel has already spoken about. Men who have sex with men who are 35 years or older, transgender women who are 35 years or older, men who do not have sex with other men, age 45 and older, and women of any sexual orientation, age 45 and older. And an important thing about these guidelines is they also speak to the other groups that Joel has mentioned: people with vulval dysplasia or vulval cancer, men who have sex with men without HIV who are 45 years or older, and transgender women without HIV who are 45 years or older, and solid organ transplant recipients who are recommended for screening 10 years post-transplant. They also describe a second risk category, who are people who have a cancer incidence up to 10-fold higher than the general population. And they recommend that this screening happens as a shared decision-making process. And they recommend for folks who are 45 years or older, the provider and the patient have a shared decision-making process if the patient has a history of cervical or vaginal HSIL, cervical or vaginal cancer, perianal warts, persistent cervical HPV-16, or other immunosuppression or chronic systemic steroid therapy. So it's really trying to make sure that there's recommendations for risk for those who have the highest risk, and then some shared decision-making in other groups. The guidelines go on then to describe how to screen among people that are being screened. The These guidelines recommend both digital anal rectal exam, called DARE, and anal cytology with or without anal HPV testing. And then if someone has a normal result, they recommend screening in 1 or 2 years. And if they have an abnormal result, they move directly to high-resolution endoscopy. And it's important to keep in mind that these are evidence-based guidelines, but they were generated by a specialty society. On the next slide, you'll see the guidelines that come from the federal government. And the reason the distinction is important is that they differ slightly, and also because the governmental guidelines are ones that often influence what insurance covers. And this can be important for patients because, as we know, none of these screening tests or treatment are free. And so people have to think about what is covered by their insurance and what they can afford. So you can see at the top that the guidelines also are limited to asymptomatic individuals diagnosed with HIV. So keep in mind that these are HIV-specific guidelines. So for men who have sex with men and transgender women who were 35 years or older, and all other people ages 45 years or older living with HIV, they ask a primary question: is HRA available? We know that it's not available in all settings, and so the guidelines differ depending on whether or not someone has access to HRA. If they don't have access to HRA, the recommendation is a digital rectal exam. And if there are no symptoms and no abnormalities on the digital rectal exam, they recommend repeating it in 1 year. If there are symptoms or any abnormalities on digital rectal exam, they recommend standard endoscopy, keeping in mind this is only for folks who don't have access to high-resolution endoscopy. And we are going to give a plug later for people increasing access to high-resolution endoscopy. So in that setting where HRA is available, they recommend assessing symptoms and collecting specimens, including cytology with HPV typing if available, and a digital rectal exam, similar to what we saw in the society guidelines. If there are no symptoms and abnormalities on the rectal exam, then you go to the assessment of the cytology and HPV results. If there are any symptoms or abnormalities, then you go directly to HRA. So hopefully that sounds familiar. Then on the next slide, it describes what to do if somebody had HRA HPV co-testing performed, what to do if they had the cytology performed and they had a normal digital rectal exam. Then you decide if they had HPV testing, co-testing done. Then you can see on the right, it walks through an algorithm there, and on the left, it says what to do if there was not co-testing performed. No co-testing, you follow the cytology. If it's normal, you repeat it in a year. If it's normal for 3 years in a row, then you can go to every 3 years. Very similar to what we see in cervical screening. If it's an ASCUS, then you go directly to HRA. If you have access to co-testing, then the results then depend on that. If the cytology is normal, then you look at their HPV results. If it's negative, you follow the same process. Repeat cytology in a year, and every 3 years. If it's positive, but there's no typing done, so you don't know if it's high risk, what high risk type it is, then you repeat in 6 months. If it's positive and you know that it's type 16 and 18 negative, then you can repeat in a year. If it's 16 or 18 positive, you go directly to HRA. And don't worry, I'm going to summarize these at the end because it's a lot of detail here. For ASCUS, then again, you look at whether it's HPV high risk, negative, or positive. You repeat in a year if it's negative and go directly to HRA if it's positive. And obviously, if they have LSIL or higher, then they go directly to HRA. So looking at the guidelines to compare them, there's the society guidelines at the top, which we've already gone through. There's the NIH CDC governmental guidelines in the second row. And then ASCCP has guidelines that also cover testing, looking at high risk, recommends screening only people at high risk, people who are HIV positive, have lower genital tract disease. And when to start really varies based on ASCCP versus the 35 to 45, which are pretty consistent within the societies and the CDC guidelines. The key components that differ within those guidelines is to remember that the AIMS guidelines focus specifically on all groups. They disaggregate people living with HIV and people not living with HIV. They cover women living with HIV and women not living with HIV, and they include transgender people. The NIH federal guidelines focus specifically on people living with HIV. But they all have general principles in common. I'm going to cover that on the next slide. For all the guidelines in general, they recommend men who have sex with men and transgender women with HIV start screening at age 35. Other people with HIV or men who have sex with men and transgender women without HIV start at 45. For folks with solid organ transplant recipients, they start 10 years post-treatment, and individuals with precancer or cancer of the vulva start within a year of diagnosis. And then for folks who are 45 years or older with high risk factors, as are listed here, they're recommended for screening, and often this is in with some shared decision-making with the healthcare provider for other factors that are not listed here. So given how, how many guidelines there are, the general principles and some of the nuances between those guidelines, it's important that providers think about how to talk to patients about anal cancer screening. We know that there's multiple societies now and federal guidelines around screening. Joel has presented some of the data about how important it can be to screen so that there can be early treatment. And Daniel has shared his story about some of the challenges he had with his healthcare provider in getting diagnosis in the first place. So on this slide, we provide some general principles about talking to patients. One of the most important things to do is to normalize the conversation. This is a conversation that shouldn't necessarily require a specialist. Often HIV care providers will have this conversation, but primary care providers can have this conversation. General practitioners have this conversation. I'm a physician assistant. I can have this conversation. Nurse practitioners have this conversation. Making it a routine part of care is really important. Doing so not only ensures that every patient has the opportunity to be screened for anal cancer, it makes it routine. It reduces embarrassment and stigma associated with talking about the anus or talking about sexual practices. And no matter what strategy you take, informed and shared decision-making is important. Providing a clear rationale for why you're recommending anal cancer screening, what the process will be, and what the potential outcomes will be. And always, whenever offering an intervention for a patient, allowing room for questions and to understand and respect the patient's values. And sometimes it can be important to address stigma directly, explicitly acknowledging the stigma and taboo associated with anal cancer and with anal intercourse. Creating that safe, non-judgmental environment so that there can be open discussion, especially for men who have sex with men, transgender individuals, and women with HIV. It's important to discuss common concerns, which are fear, discomfort, judgment, often stemming from stigma, offer reassurance, provide practical information, and as I mentioned earlier, in terms of guidelines and insurance, talking about the cost, the logistics, and the next steps that will happen if their screening is abnormal. All of those things are important.
Tony, I wonder if it's worth at this point asking maybe Daniel whether you have some thoughts about talking to patients that Tonya hasn't brought up. What do you wish would have happened in your case or for other people who now know are at increased risk of anal cancer?
Sure, there's a lot of things that Tanya said that looking back, I was like, "Ah, why didn't I open my mouth? Why didn't I say more?" And it was that, again, there's this block that happened in my brain looking back between being an advocate and being a patient, that all of a sudden being in the patient seat, I just forgot to ask the questions. Even though as an HIV educator, I was talking about sex and sexuality and penises and vaginas, and I was like, it's a common conversation. But once you're in the patient seat, and I think a lot of that stems from culture. I was brought up in a home where my mother, who was my primary, uh, who was assigned to take me to the doctor, she never was completely honest with her doctors. And I think just culturally, I learned to not be completely open. Um, she was a smoker. I tell the story often. She was a smoker, and when I would translate for her at the doctor's office as a young kid, they would ask her, "Do you smoke?" And she would say no, although she smelled a cigarette. So I think some of those components stuck in my head is like, don't tell the doctor everything because they're gonna find something wrong. So the itching, the spotting, the problem with going to the bathroom, all those things, I was the fear of being judged more, like I said earlier, for either my diet as a Latino or my sexual activity as a gay man, I just didn't want to start this. And I think that happens for a lot of men, whether you are a straight Latino man or a gay man. Having those conversations with your doctor are difficult. And then having them with your peers is even more difficult because you don't want to talk about being sick or having an issue. And I'll close with this. Um, as a gay man who was sexually active, where I was submissive most of my sexual life, anal sex was an important part of that relationship with my partners, particularly at the time. I was only 3 years into the relationship with my current partner. So it was, I didn't want to hear that maybe sex was not going to be part of the intimacy they were going to have. So bliss in ignorance, I guess. But looking back, I really do wish that I released some of those barriers and blockages that I was carrying around as a Latino man and as a gay man.
Tanya, I know you're going to be talking about speaking with different populations, but I think you said something super important, which is worth repeating, which is that in the current vision for the screening programs that we're hoping will become more common, a wide variety of medical professionals are well equipped to do this. You mentioned PAs, nurse practitioners, primary providers, family doctors, HIV providers are all very capable of doing this. But you also mentioned a really important point, which is it is critical as you're thinking about this to figure out whether you have the capability of either performing high resolution anoscopy yourself or having someone to whom you can refer your patient. HRE is a difficult technique to learn, and there still are not anywhere near enough people who are trained to do it. So many people who are taking care of the populations that we've been discussing actually don't have someone to send their patient to for HRA. And if that is the case, then we believe that you should not do the screening tests that Tanya has described. Tanya has described the cytology, the HPV testing, because we don't think that it's ethical to do a test if you don't have the ability to act on the results. That said, the provider is not off the hook. There's two things they really need to do. Even if you don't have capability of referring your patient for HRA or doing it yourself, you need to have the discussions that we're talking about as part of a routine medical evaluation, history, and potentially physical. And the other is to do that digital anorectal exam that Tonya mentioned. We all know how to do it. We were trained to do a digital, primarily feeling for rectal lesions, but you are passing by the anus as you're putting your finger in, and it's a very well-suited technique for also feeling for anal lesions. So we're hoping that for anybody who falls into these risk categories, that they will have something done, either the discussion plus a DARE, or if HRA is available, discussion, screening, and a DARE in that order specifically, because the screening tests that need to get done if you're going to do it, the cytology and the HPV test, the samples have to be taken before you have lubricant in the anal canal. So you need to know in advance, are you going to be doing those screening tests or not? And if you are, you talk to the patient, you explain everything you're doing, and you collect the samples before you put any lubricant in. Then you can do the digital anorectal exam with the lubricant. If you're not doing the screening test, the cytology and the HPV, it's the discussion and the DARE. And in that case, of course, you can go right to your lubricated procedure, by putting your finger in. So just a reminder that it's really important to consider in advance whether you have capability to send your patient for HRA. And if you don't right now, we do recommend the DARE, but as Tonya mentioned, we would love to get more people involved in performing and learning how to do that technique. Back to you, Tonya.
Thank you, Joel. I think that was a beautiful reminder that we all have the opportunity to make a difference in patients' lives. And the conversation and the exam, at least the DARE exam, is available to everyone to do in the office. And especially important, the reminder about collecting the samples before using lubricants. I also think when you're talking to different patient populations, it can be really helpful to think about um, who they are, what their experiences might be, and what you might want to emphasize in conversations with them. We do know that HPV vaccination is available, and for younger people who fall under the guidelines of being eligible for HPV vaccination, there should be a focus on primary prevention. As was mentioned, it is an effective vaccine. It can be really important to prevent having someone go all the way to anal cancer when there's an opportunity when they're young to prevent HPV acquisition. As Joel also mentioned, most of us are exposed to HPV at some point in our sexual lives. And for older folks, it's important to focus on that secondary prevention, the screening. When talking to people with HIV, it's important that people understand their risk. Daniel talked about not understanding until after he was in the Google rabbit hole that he had increased risk for anal cancer. And that might have changed the thought process around what to discuss with the healthcare provider if he'd been aware of that. So highlighting the increased risk, reviewing the guidelines that recommend annual screening and symptom assessments and DARE, and helping the patient understand why you want to do it. For people with HIV, you want to tailor the message to risk-based screenings and clarify what those risk factors are. And for any LGBTQ patient, men who have sex with men, transgender women, and other folks at increased risk, you want to avoid assumptions in general about any kind of care, but especially about care around such sensitive issues as anal health and sexual activity. It's important to use inclusive language, to respect privacy and confidentiality. And I always let patients know what I will and will not write in a chart when we're having a discussion, because sometimes that's important to people, and respecting their desires to determine what you do and do not share about their intimate lives in a medical record can be really important. So to summarize all that in terms of communication tips, use simple language, avoid using jargon. I loved how Joel was like, put your finger in, right? Some of us will say DARE or digital rectal exam, but it basically means you're going to put your finger in someone's bottom, right? And you're going to feel around to see if anything's abnormal. Validate the patient's concerns and normalize their fears or embarrassment. You don't want to tell them not to feel embarrassed, right? Because they feel what they feel, but letting them know that you don't feel embarrassed. This is part of taking care of their bodies. Explaining the benefits of early detection and especially improved survival. And people learn in different ways. So sometimes people want to hear you talk about it. Sometimes people need written information. And I've even sent people to like trustworthy YouTube sites if I know that they learn better by watching a video or hearing someone's story. That can be really important. And then to reinforce those messages at subsequent visits. And Daniel runs this fantastic organization. Referring people to their peers and peer support networks or patient support resources can be really important too. I feel like you want to say something, Joel. Is that true?
I actually want to, before we close, see if Daniel has any words of wisdom for us that you'd like to add.
Wow, no pressure on the words of wisdom. I think uh, I wish we could make a t-shirt that said, put your fingers in, and take it to every doctor's appointment we have. It's such a simple and yet funny line, but so impactful. I looking back at my history as a Latino gay man living with HIV who had been exposed to HPV. I wish we had taken the time to just do that, to tell my doctor, hey, can we do that extra test? But because at the time, the numbers, the age was higher. We didn't have all the information. So I guess my words of wisdom for anybody who watched this to the end, talk to your doctor. Let down your guard, break down those barriers, whether they are cultural, religious, or social norms that you left behind that don't allow you to talk about your bum. Talk about anal cancer. Speak to your doctor. If you're sexually active, if you're living with HIV, you've had sex, uh, go to your doctor and have the conversation. I guarantee you, as somebody who has lived it and survived it, I wish I could go back and have those moments of embarrassment in the doctor's office and not have to go through everything I go through. So let your doctor put a finger in it and stop anal cancer.
I definitely want that t-shirt. Let your doctor put a finger in it and stop anal cancer. I see it on a billboard.
This is
Never,
a field which does lend itself to quite a bit of opportunity for humor, if you're willing to go there. Um,
Yeah, Joel, before we go, I do want to just take a moment to talk about interprofessional communication. Just because so many of us work no longer work in isolation. We work as part of a team, right? There's nurses and social workers and um, doctors and NPs and PAs and all those folks that work together in the team. And it's important to communicate within the team and to collaborate. So, like for example, for the flu vaccine, for many of us, we have the medical assistant or the nurse who takes the patient back, offer that before the provider ever comes into the room. So there might be an opportunity in your practice, depending on how it's set up, to provide that kind of information for people, and that can be reinforced and more detail provided when a healthcare provider comes in. So having those kind of conversations, understanding the unique contributions of everybody on the team and how they can contribute to ensuring that patients have appropriate anal cancer screening is important.
Thank you for adding that, Tonya. That's so important. This is a team sport for sure. So our time is just about up. So let's summarize what we've covered today. A reminder, HPV infection, anal HCL, the precursor lesion, anal cancer are most prevalent in men who have sex with men with HIV, but there are other high-risk groups, including other groups with HIV and women with prior HPV-associated disease, particularly in the vulva, but also in the cervix, and people who are immunosuppressed for reasons other than HIV. It's important in these high-risk individuals to identify the precancerous lesion as shown by the anchor study and treat them, where the treatment, which we haven't had too much time to discuss, the recommended treatment in the NIH guidelines is office-based electrocautery, typically in the form of a technique we call hyfurcation. So these new recommendations do give guidance on evaluating also the symptoms that somebody might present to their primary care provider with, and how to screen if you have that capability of doing so. The screening protocols, as we've discussed, will depend on whether or not HRA is available. And although we focused today's session on secondary prevention, again, primary prevention, particularly for people who are earlier in their lifespan, 9 to 12 for HPV vaccination, and then individuals in the so-called catch-up phase, potentially up to age 45, should also be considered for HPV vaccination. And then I'd like to leave you with SMART goals. So SMART are, to remind everybody, SMART, measurable, attainable, relevant, and timely goals. And the things that I think fall into that category for this discussion are to offer HPV vaccination to all eligible people and document that in your electronic healthcare record, to implement the screening guidelines as we discussed on this session, and also, and didn't have enough time to go into this really, but to implement the kinds of tips that Tonya was talking about, talking to patients about anal cancer. If you're new at this, then consider doing role play, practicing with other professionals, practice potentially with patients who are willing to work with you. I think you will find that helpful and rewarding. So with that, I'd like to just remind everybody here to please visit the CMEO Infectious Disease and Oncology Education Hubs for additional relevant resources and activity. Lastly, but certainly not least, I want to express my enormous appreciation to my co-panelists today, Tonya and Daniel, for being here and being willing to share your experiences and to thank you for attending the session, and especially for working to provide the very best of care to your patients to try and prevent anal cancer. Thanks very much.